My name is Q-Sean Miller. I'm a senior interpersonal communications major, and I'm here at TSU's Health Clinic to interview Dr. Johnson.
Luckett Johnson, and yes, I'm a physician. Here, staff at the clinic. You also have a private practice.
Okay.
I received a master's degree in analytical chemistry from the University of Florida. I don't believe I took any communications course. You do have to communicate a lot in private practice or seeing patients, so that you get to talk to a lot of patients. You see a lot of and evaluate a lot of different problems. But you know, medicine is made up of, like myself, a clinical type person. But we have pathologists, radiologists. These physicians do not see as many patients. They see looking at films, they look at slides, so they don't interact as much with patients. So they don't get to talk to patients as much. Whereas patients who are in the clinical practice, like I am, we get to talk to patients, interact with patients, and find out what their problems is, try to solve their problems.
Okay.
Well, I'm a physician. I trained at Baylor College of Medicine, graduated in 1979. Been in private practice since finished training.
Okay.
In private practice, especially as you get older, you see a lot more degenerative diseases. These are diseases that come on with age.
Okay.
And so you see a lot more arthritis, diabetes, hypertension, cancer. So when you look at a private practice, you see a lot more degenerative type diseases. Whereas here at the university, it's young people, so you don't see the degenerative diseases. You see more acute type diseases and injuries. So you see lacerations, you see sprains, strains. You also see sore throats, sinus infections, bronchitis. So it's a different spectrum when you see young people as opposed to older patients.
Okay.
Initially, I felt I wanted to be in healthcare. I'm not sure if it was to be a doctor, but I did like healthcare. And sometime during undergraduate training, I decided to be a chemist. Mm-hmm. And when I received my master's degree from the University of Florida, I had to determine what should I do. Stay in chemistry, and there were several other opportunities at that time. Get a PhD in environmental engineering, PhD in biochemistry, and so, or medicine. So I had to choose between those. And what I ultimately did was chose medicine. It was just, what do you want to do with your life? You know, what type of lifestyle do you want to lead? And so going down different paths will lead you in different directions. So if you feel that you want to be in a laboratory around test tubes and writing reports and things like that, then you really should receive a PhD, because that's what you're going to be doing. Whereas in medicine, you're going to be around people. You're going to be interacting with people, trying to help them and cure disease. So when you look at all of the opportunities, medicine offered the best one out of the ones that we're looking at.
Okay.
I think the best thing is the people interaction. Each person is an individual. Sometimes it seems as if physicians treat the same thing the same way, but each individual present in a completely different way. So each person, you have to look at them as an individual with an individual problem. Not that every sore throat is not the same. So you must differentiate how to treat it based on how the patient present and what your physical findings are.
Okay.
Well, I think early on it was not getting enough sleep because you would always get interrupted. You would get telephone calls at 2 a.m., 4 a.m., 6 a.m. So your sleep was not like a solid 8-hour sleep. And also, many times you would get up at 2 o'clock and you get back in bed at 4:30 or 5 o'clock, and then the phone rings at 6 o'clock. So the convenience of sleep is lost. That's probably the biggest thing. Well, I think primarily with patients, you must ascertain why did the patient come to the physician? What is the problem? And it is best to let them say it in their own words, not try to put words in their mouth. But usually I ask them, what brings you to the physician's office today? Or what is your problem today? So that they say it in their words. You don't try to say, I note that the nurse put down that you have a sore throat. You let them define it, and you'll be surprised that sometimes what they put on paper is not what the problem is. People look at medicine from different cultures in different ways, and so you have to take that into effect. Some people do not like to communicate about what their illness is, so you have to sometimes go around and about and make the patient at ease so that they will communicate what the real problem is. Because sometimes they would start off saying that they have one particular problem, but that really was not the problem that brought them to the physician. There's another problem. And so you have to get over that first problem to get to the real problem. And so each culture looks at medicine a little bit different. And here in the U.S. it's fairly uniform, so you don't have as much, but when you get into, but we have a lot here at the university and other places. We have a lot of patients who come from other countries. They come from Africa, they come from Europe, they come from South America, from Central America. So all of those patients, they bring their own culture with them, and so you have to interact with them in an appropriate way.
Okay. So,
let's stop here. Let me go see this patient.
Okay.
Just pause it, and I'll be back in a few minutes. I did know a little Spanish, but that is gone by the wayside. Usually through interpreters. Patients, you will see that patients usually either speak English or they speak fair English, enough to tell you what their problems are, or they bring family members who can speak English, or you use an interpreter. The majority of the time, most people who say they don't speak English actually speak some English. So you don't have a big problem with communications with most patients here in the U.S. Here we mainly use Spanish, so we have a lot of Spanish publications. There are a lot of, in Houston is a very diversified city, so you have a lot of different languages spoken here, but really most of the written material is going to be in Spanish and English.
Okay.
No, I think most patients have gotten used to either seeing male or female physicians, and actually when I started practice there were mainly male physicians. Now they're about 50-50. So you can see females make up a large portion of the population, but I don't see any, I've never heard any female physicians talk or say that patients are not at ease with them seeing them. So I don't think that's a big factor, the gender. Well, I think, when you're just out of practice, you have a lot more energy. Energy tends to go downhill as time goes on. So you don't, usually have as much vigor as when you first start. So I've been in practice about 30 years, so my vigor is going down. But it's not a big hindrance. But what you will find is that in private practice, patients get old with you. So when you start off, you have mainly, say, 30 to 40-year-olds. And as you get older, your patients age with you. So you become 60 years old, most of your patients are elderly. Yeah. You know, so that slows you down a little bit as well. So you don't tend to work as hard, I guess, as you get older, simply because just like if you were an athlete, you know, when you're young, you could do a lot more. You know, when you're 60, trying to do something like participate in sports or something, you can't do it. Well, physicians and everyone else in life slows down as you get older. So it's a normal process, but it's not a big hindrance to practicing. A lot of physicians practice into the 90s, so you know, it's not unusual. As long as your mental ability is still there, even though you can't walk and stand as long as you used to, you're still okay.
Okay.
Being a physician is fairly constant. There's not much change from when you enter practice until you've been in practice for many years. The spectrum of patients change. Some of the medicines, of course, change. Some of the way you make diagnosis or diagnostic tests change. So you see some innovation, but the actual practice of medicine and how you think about patients do not really change. You do need continuing medical education, and the state requires a minimum of 22 hours per year of continuing education. So you have a minimum standard you must meet to continue to practice.